And thank you for joining us, obviously, here in real life and online. It's a pleasure to be here. I am an acute medicine doctor by background, so if you'd have asked me 5 years ago would I be speaking at a midwifery and maternity conference, I probably would have said no. But it's a real privilege to be here. I've learnt so much myself being at this conference today, but I also want to instill a bit of excitement about the world that I live in, which is digital health. I've been in digital health for the last few years, built a number of solutions across the NHS, academia and industry. One of those is ERA. So Caroline and I met on the NHS England Clinical Entrepreneur Programme, which is effectively mopping up all the healthcare professionals with amazing ideas, supporting them turn them into a reality. So today I'm here to talk a little bit about digital. It was really quite exciting to see one or two other digital solutions in the exhibition hall. But we do believe that there's an opportunity here to support one another in terms of, supporting our workforces, supporting our service users, and together we can start to create a more effective care providing NHS. I won't go over this because I think we've pretty much covered off everything that we do. Caroline is my co-founder, who is based in the Southwest, hence why she is virtually enabled, because that's the kind of conference we are. Between us, we're both clinical by background, but really have a desire for wide-scale impact across the UK NHS and other healthcare services across the globe as well. So I'm going to hand over to Caroline now, who's going to give a bit of background as to what incentivized us to actually work on something like ERA, and then I'll come back to talk about where we are today.
Thank you, Michael. So firstly, I just want to check, can you hear me okay?
Yep.
Excellent, it's working, that's brilliant. Okay, so the why. For me, really, the why is absolutely rooted in human factors. So in essence, human factors is the study of human performance within a work environment. It's essentially sort of a design science that looks at how to improve human performance by examining the interactions humans have within their working environment, whether it be their colleagues, their footprint of the maternity unit, the digital solution they're being asked to use, the pro forma. So we know that improving performance will improve outcomes. But unfortunately, there is always a range in how we perform, either how we perform as individuals or how we perform as a team. So if you look at this bell graph in front of you here, you can see that on the far right, occasionally we perform exceptionally well. Our patients have a fantastic experience in healthcare. The outcomes are as we would intend them to be. We enjoy our jobs. We skip home every night thinking, thank goodness I'm a midwife, I love my job. Occasionally, on the opposite side of that curve, you've got poor performance, whether that be individual or as teams. Now, we know during this time that patients have a really poor experience. We know outcomes are not what we would want, and that's when never events and serious incidents occur. But luckily, most of the time, in the middle there, I hate to say it, but we're all pretty average. We are average in the fact that we provide averagely safe care. Our performance is average. The patients, by and large, have a good experience. So what I want to know is how can we either shift that bell curve right over or flatten the bell curve so that we can standardize performance, so that we can get rid of the unwanted variation that leads to never events and serious incidents. Next slide, please, Michael. So that's not an easy task because healthcare is complex. It is a complex socio-technological system, and it has so many different factors, whether it be organizational management, engineering, social, psychological. So many different variables affect how we work and how the systems function. If I put my patient safety hat on, my human factors hat on, I know there is a hierarchy with interventions that will help improve safety and stop humans from making errors. So think about it like a triangle. Right down at the bottom are the least effective interventions. Within them, you have training, policies, emails, reminders, really quite ineffective in stopping humans from making errors. But right at the very top of that pyramid are the most effective interventions, and they are automation, computerization, and AI. And that's why I believe if we enhance the capability of digital, we can really start making huge transformations within maternity safety. Michael, next slide, please.
So thanks, Caroline. So whenever we think about innovation, whenever we think about digital, there's no point adopting something that doesn't make any sense, right? I really like this quote, and I love a quote. So change occurs when the pain of staying the same is greater than the pain of change. I'll say it again. So change occurs when the pain of staying the same is greater than the pain of change. So you can use that in any walk of life, right? The reason that people change jobs is because they're not happy in their jobs, and actually going in and handing your resignation is easier now than going and turning up to work. But we need to think about the same thing in terms of our day-to-day working lives and how do we make it easier. You know, yes, innovation is complex, it's expensive, it takes time, it takes validation, but actually if it's better than what we currently have, we really need to consider it. So when I think about innovation, I always think about the drill. Does anyone know why the drill is an amazing tool? It's because 100% of people that buy a drill do not want a drill. It's probably the most fraudulent business ever, because what do people want? They want a hole in the wall. So it's actually about, you know, I could take a sledgehammer, hit it against that wall and get a hole in the wall, but is it going to be 5 millimeters wide? Is it going to be perfectly spherical? Am I going to have a nice flashy light show me where to drill? No. So it's always about, what do I want? What is the problem I want to solve? I want a hole in the wall. I can't use a sledgehammer. I need to use a drill. So always think about what the actual outcome is of what we want to achieve through innovation and through digital. And then we work backwards. Once we've got the problem, how do we solve it? So thinking about the benefits with digital, so it's about easier access to information. Most of us are moving to electronic patient records now. I say most of us because some trusts are a little bit behind, but on the whole, we should be becoming more digitally mature. And this is coming from the centre, right? So this isn't trust by trust. We all have to move to a more digital NHS. But actually that should enable us to have easier access to information. Maternity is one of the best places for this, right? We care for people in the community, we care for people in hospitals, we care for people in specialist centres. So we should be able to access that data regardless of where the patient is. And it really frustrates me that the data doesn't move with the patient, it moves with the organisation. So I have a massive drive with this nothing about me without me movement, which is all around how do we move data with patients rather than buildings. Then it's about continuous monitoring. Never before have we been able to hold our head with those horrendous stethoscopes, which I did use at medical school. I've never used one since. And listening to the fetal heartbeat. You can't do that continuously, but now we have tools that enable us to continuously monitor both the birthing parent and baby. And I think that's such a fantastic opportunity. But then once we've got that data, how do we learn from it? How do we enable ourselves to do even more exciting things? Caroline touched on artificial intelligence, and this is just the start of an ever-changing ability to enable our team. We're not going to be replaced because you can't replace the human because you can't sue a robot. But it is about how do we actually support our workforce to be more digitally enabled, more effective in the care that we can provide. And then the whole system approach. I'm fully aware that this is not a single solution. Digital and clinical needs to come together to solve problems. We cannot just come in and tell an NHS trust that this is what they need. We need to work with the workforce to understand what the needs are, what the grand challenges are, and solve them together. So it's as much about empowering senior leaders within the trusts, empowering, it's great to see so many students here today because they are the workforce of tomorrow. And I think if they have a digitally enabled mindset, then they start to think about how we can solve problems that we as healthcare professionals, as people with council numbers, actually understand. So that's a really important point that everyone should be involved in these processes. So I just wanted to touch on a couple of case studies around digital and the good, the bad and the ugly. Starting off with apps. So obviously maternity is probably one of the best known specialties for mobile apps, right? We're giving parents, birthing parents, power over their own health, which is a fantastic thing. It comes with its drawbacks, of course. Regulation is something that we have got quite right in the NHS actually in terms of clinical safety, data protection, cyber security, interoperability and trying to enable apps to work with one another, and then accessibility and usability. We're not quite there yet. We know there's a health inequality across ethnic groups. We know there's a health inequality around first language because we don't document what someone's first language is in the NHS. It's not part of the demographics. And why is it not? We should know what language people speak so that we can deliver care to them in an effective way. And there's some great drives like Bola, who is the director at NHS England for Health Inequalities, has this Core 20+5 movement that we are proud to be partaking in. But taking it back to the apps, it's given us the ability to distribute information in such a meaningful way. But it does come with its, it does come with its challenges of how do we prescribe apps? What safe methods do we have to actually prescribe apps as a healthcare professional? What's safe, what's not safe? It is an open market, right? Anyone can build an app, and as long as you pay the app providers, they'll publish it as long as it meets their standards, but doesn't necessarily meet the NHS standards. So we owe it to ourselves as a community of healthcare professionals to also regulate ourselves what we are giving to patients. And we're really fortunate that there are some really well-known apps out there today that help with the care that we provide, and it does make our lives easier because it explains things in a new way. It enables us to support people at home, but it cannot replace the information that we give in person, because that is equally important, and that care provision has to come from the care providers. I'll hand over to Caroline for this one.
Yeah, so this case study really is about wearable devices. And I think for maternity, there was an explosion during the pandemic. So obviously during the pandemic, we were looking after an at-risk group, an at-risk cohort of pregnant women who were struggling to keep access with their standard maternity services because they were trying to respect the stay-at-home message. They were identified as vulnerable and they felt vulnerable. Clinics were often turned into remote clinics, so we lost that patient contact that we used to have. And a lot of scheduled antenatal appointments were actually scaled right back. So there was a real desire and boom to adopt wearable devices. Now I'm talking about things like SATS probes for women that can monitor their own saturations if they had COVID-19 at home, home blood pressure monitoring. Now what's interesting was these weren't new technical devices. This was always available, but it was the pandemic that pushed the need onto us really. And what was more exciting was the rapid acceptance from both women, partners, families, and clinicians. Suddenly, we were like, yes, we need this, bring it on. We haven't fully explored remote technology yet. So you can see on the screen there in front of you, this is a remote fetal monitoring system. Now, I don't know anywhere in the UK that actually trialed this. I know it was being trialed in the States. And when I look at the data, initially I think, no way on my labour ward, because it reports actually only being able to recognise fetal heart rate patterns 90% of the time. So I'm thinking, nobody's going to sell me a CTG that only reports accuracy 90% of the time. But you have to think differently. So these devices are designed to be worn for 48, 72 hours. So if you're looking at being able to monitor a fetus for 90% of the time over 72 hours, we're talking about a very different picture than the snapshot CTG you get for a lady that might come in twice a week to a daycare assessment unit because she's got prolonged preterm rupture of membranes. So it's about making sure the devices that we take on are safe and that they're clinically tested, but also making sure that we are flexible in our approach to perhaps start to work in a slightly different way and think outside the box with what we do currently and what we can do to improve patient safety. Devices should not just be there to monitor, but they absolutely have to demonstrate a measurable benefit for the patient or the health population.
Just before we move on, I just want to touch on the predictive analytics side of this, because I think the remote monitoring thing is a potential thing. But what is a real thing is an opportunity to actually start to predict. So with CTG monitoring, for example, how do we know, or how can we monitor trend recognition so that we can start to predict when a fetus becomes compromised? When we start to see decelerations, is there any patterns that we can associate? And if we have a data set large enough, we can say with some level of confidence that we can start to early warning score this physiology. And I think there is an opportunity to do that. But again, how do we step away from actually having a midwife have their eyes on that CTG? And there is a massive risk associated with that. So I think, yes, we can talk about this. We can start to experiment with this. And we're doing a lot of research around AI and predictive analytics at our organization. But we have to also accept that this is not going to happen overnight. This is going to be, we need a lot of trust from the workforce. We need a lot of evidence from the solution itself, the software itself. So I think let's be anxiously excited about this new era that we're heading into, but at the same time approach it with caution. Sorry, Caroline.
Thank you.
There we go.
So the other case study we want to talk about is something that Michael and I are directly involved with, and it's called ERA Systems. ERA stands for Emergency Role Allocation. So it was a concept that came up through observing what resus bays do in emergency departments. So they basically operate with something called Advanced Trauma Life Support Principles. One of the key principles with ATLS training is role allocation. And that's because they get the phone call to say, you've got a pediatric trauma coming in 5 minutes. So people could allocate their roles before the patient arrives. And what I observed was staggering. It was brilliant. I've run enough simulated emergencies and real life emergencies to know that as clinicians, we're really good at managing emergencies, but we're not good at streamlining who comes into the room and who goes out of the room and what order we do things in. So ERA Systems is a very simple concept that allows the clinician in the room to touch a screen to communicate to those on the outside of the department to say, I'm having a postpartum hemorrhage. So people then know what they're attending. The screen helps support how many people need to come in attendance, and it also ensures that people come in with the right equipment. So you're reducing unwanted exits and entrances. You're reducing too many people, which often hampers communication during emergencies. And also you are sort of maintaining situational awareness across the whole maternity unit so that each department knows what's going on in which area. Michael, over to you again.
Just finishing off with this as well, there are benefits far beyond the human factors that we see across ERA. So the thing that gets me really excited is we're moving to an EPR, an electronic patient record across the UK, which means that we will lose the ability to take paper notes into emergencies. ERA, for me, is the ability to actually support the scribing of emergencies across not just maternity, but across the NHS, because we're going to lose that. We're going to lose the real-time ability to capture data across every emergency. That leaves us wide open to litigation. It leaves us wide open to root cause analysis and failures of care because we just didn't capture it in real time. Writing in retrospect is not the same. And therefore, ERA for me is a really important part of that emergency management pathway of being able to, in real time, capture that data. And then we retrospectively write in all the other bits about who did what. We write in all the other bits about, the outcomes and what happened. But being able to say that we responded in this amount of time, it takes that ownership away from the team because we know the teams work really hard. And if we then just document really poorly because nobody has any time, that's not fair. So there is a piece around supporting insurance premiums and supporting litigations. I mean, if we can prevent one fetal brain injury or we can prevent one legal case against that, it pays for the application for 80 years. Just let that sink in. It is ridiculous that these innovations, the return on investment that they could potentially have. So that's why we believe in it, because we feel that we have to enable our workforce to be able to document in real time what is happening during an emergency. Just taking it back a step. So if you want to try your hand at digital or innovation, it's possible. One thing I would say that is we spend a lot of time in the theory-based side of things, but the best way we can solve problems is by trying new things and taking risks. Now, we are a very risk-averse industry, healthcare. We want it to take as little risk as possible. So it's about how do we safely take risks. And by doing things on the job, we get to try new capabilities. Often trying things in a simulated environment is great, but then it's about how do we safely implement that. So I'm happy to support anyone that has ideas, understand, how they might do that in a real world setting. And I do this all the time because on the program, I was actually one of mentors to several innovators. And that's what we do, is understand and realize how we turn ideas into reality. As intrapreneurs, i.e. entrepreneurs that still want to work for the NHS, as well as entrepreneurs who fly the nest and go and start their own business, and each to their own. Lastly, I've touched on this vaguely, so I won't dwell on it too much, but regulation is probably the biggest barrier to innovation. I like the saying, because I love a quote, if you invent the ship, you invent the shipwreck. So I think we all need to understand that by embarking on a new journey and inventing something, we carry a burden on ourselves to be able to mitigate the risks associated with that. So something that we spend a lot of time on is understanding what the risks are with everything we're building around ERA. So for ERA, for example, if you use it without a hardwired bell, it's a medical device. It's going to take about 2 years to get into the market. If you use it with a hardwired bell, it's fine, because all it's doing is capturing all the stuff that a hardwired bell doesn't. Hardwired bells have been around, electric bells have been around for 200 years. So we are just supporting a legacy solution with innovation, and that makes it an accessory to the medical device. So there are clever ways that you can actually still innovate without hitting yourself with massive barriers that just kill innovation, not just in the NHS, but across every industry. So it's how do we learn from these lessons, and how do we share knowledge to be able to empower people, students, midwives, senior leaders, decision makers in the trusts who actually try new things. And lastly, data. So I did a study as part of my MBA around how do we introduce value into the NHS. And it's all about data, isn't it? It's all about evidencing. Both before we've even built the thing, we need to understand that there's a need for it, the drill analogy. As we demonstrate the value, we need to be able to back up our evidence with data. So actually, as introducing the data, introducing the product or the solution into the NHS, we need to back it up with evidence. And then once it's in, it's about continuously monitoring the data that we are generating in a way that's safe, compliant, and protects the patient. Because we learn from data, we learn about prediction, we can automate based on data. And so it creates that golden thread, hence the picture, that runs throughout any innovation and any digital solution.
And that, Michael, sorry to interrupt at the end there, is one of the huge benefits of technology, isn't it? That you can then record so much more. You know, I'm sure a lot of the sort of maternity leaders in the room and online know the struggles about capturing all the maternity incentive scheme data that we need to provide. But with digital technology, you've got a much easier forum or net or way of capturing data. A bit like with ERA systems, we record the timings of when the emergency is declared and then managed, so that can inform not only governance, but also feedback into training, so we can improve what we're doing on the ground floor.
So that's it. I am based I'm Nottingham born and bred, as you can probably tell. But I live in Leicestershire, so I am based in the East Midlands, and we'll be running simulations across the East and West Midlands around ERA. So we just come in, bring some food, and we do simulation, as you have to anyway, both with and without ERA. So if you're interested, here's our generic email address, and we can come and have some fun over lunch. But thank you so much for your time, everyone. Happy to answer any questions, and thanks again.